So what I mean by that is when there are other factors contributing to a neurodiverse profile. So some of the conditions that we see overlapping, which can also cause differences in a young person. So I'm going to cover that. And then we're going to talk specifically about neurodiversity and trauma and how it presents and the challenges with that. And then at the end, we're going to cover sort of how trauma can present in an autistic population. So when we've got autistic children and young people, they tend to react to trauma in very different ways. So we're just going to go through sort of how that presents. Okay, so starting with differential diagnosis. So you may be aware of some of these things. It could be a refresher, but we tend to have a lot of overlapping profiles in terms of diagnosis. So when we see a young person to diagnose, it might be on the referral that we're looking just at autism or just at ADHD, but often that's not the case, and there tends to be a lot of other things going on. So these are the most common ones that we see. So global developmental delay, obviously is the term that community paediatricians tend to use with little ones when they're not meeting their milestones. So that obviously covers independent skills, language skills, motor skills. And then when they've got differences in all them areas that are quite evident, then they will say they've got a global developmental delay. As they get older, that then progresses to becoming an actual diagnosed learning disability, or some people say intellectual disability. And this is where, standardized tests are used. Usually it could be, education psychologists or clinical psychologists will do tests that sort of measure a young person's skills across the board. So that could be language, independent skills, functional skills, motor skills. And often these children, young people, can present as having an autistic profile because they may have some challenges across all areas of the development. So we look at that as part of the team. ADHD is massively overlapping, so I'll talk about that in a sec. And then we've also got mental health conditions, which I'm just going to cover really briefly. But we have quite a lot of depressive symptoms that we see in our autistic children. Social anxiety disorder is a massive one. And then we've got obsessive compulsive disorder as well. So I'll just cover them. And then obviously we'll go into trauma as well in a bit more detail. So comorbidity, as we say, so this is obviously two or more different diagnoses or different conditions. In the general population, neurotypical people, 40% of us tend to meet the criteria for a psychiatric disorder. So what that means is some of us may be diagnosed with anxiety or depression, and we'll go to our GP and obviously get support for that. But in the autistic population, it tends to be as high as 69%. So it's a massive increase in terms of comorbidity and challenge that autistic people face. So in ADHD, the presentation tends to mostly be anxiety as a co-occurrence. That's often seen in childhood, and depression tends to come more with our adolescents and adults when they're diagnosed with neurodiversity. So ASC, ADHD, so these are our main ones that seem to be very, very overlapping. So most of the research at the moment will say that it's about 30 to 50% of individuals with autism will also have ADHD symptoms, but there is some research that I've been looking at recently which says it could be up to 80%, so it could be actually even higher. I think the difficulty is that ADHD is a lot more stringent around diagnosis. It's a lot more based on observation of what happens in school. So you guys as education professionals, you're very, very important in terms of diagnosis for ADHD, because we need to have evidence that there's difficulties in both areas. Sometimes this can be challenging when masking is there, but there needs to be that evidence that we've seen it in a different environment, and that can be football coaches or personal tutors or anything like that. So when they've been, as long as they know the child for more than 6 months, then they can contribute to the assessment. But them symptoms are very overlapping, and we say about 2/3 of our individuals with ADHD will show features of autism. So often they tend to end up having both assessments. So we've obviously took this on board as a team at Alder Hey, and we have created our integrated pathway now so that we can diagnose all these conditions sort of in a holistic way. Rather than, you know, trying to see the child in different segments, we try and see the young person as in a holistic way. So this is just a little visual which might be helpful for you. So this is just sort of pointing out that the differences and similarities between the two presentations. So as we can see there, so ASD children can present as being impulsive. But often we find when we do the unpicking and we ask the questions, it's often because they've maybe not understood the social situation, and so that difficulty around social understanding comes around. Whereas in ADHD, it's very much just an impulsive profile. You know, they just react to situations, so it's quite different. So hyperactivity, a lot of autistic young children, they do tend to be quite hyperactive, and this is definitely part of a profile. But often what we find is when we actually assess the young person, we see that they're actually seeking some sensory stimuli. So you might have had a session on sensory already. Sensory seeking children tend to be up and about, up on the feet, really, really seeking that feedback, but it's for a very different reason than just excessive fidgeting, which is part of an ADHD profile. Then we've got inattention. Often some autistic young people, maybe you may feel that they're not paying attention and they're not engaging, when actually it's just because they're focusing on something really intensely. So that could be linked to their rigidities and their intense interest. So there's something called monotropilism, which is like a new unified theory of neurodiversity, and that talks very much around individuals being focused in their own world and finding it hard to move from their own world into our world where they've been, where demands have been placed on them. So then we've got repetitive behaviours. So a lot of young people with ADHD, they can have lots of fidgeting attention, lots of shifting attention, and it may present in a way that it's repetitive behaviours, but often it's actually not the case, and it could be just to do with impulsivity, whereas in ASD, repetitive behaviours, but excuse me. Repetitive behaviours tend to be just part of the profile anyway. So part of the diagnostic criteria, sorry, I'll just sorry, God, can't speak. So part of the diagnostic criteria does actually include stereotype movement. So we're looking for the hand flapping, rocking, moving around. So, and then we've got social challenges. And then we've got the sensory differences as well. So even though there are so many similarities, there are these differences as well. So this is why when we do a full assessment, we can really try and unpick the differences and the challenges between the two. So I've got a little video here, but I'm not going to show it. I'll just leave it in the presentation for you to view later. It's just a really nice visual that you can use to help your whole schools really understand the differences between ASD and ADHD, so that when you're referring to pathways or referring for diagnostic assessment, you can focus in a little bit more on what you think you're seeing. Okay, so depression. So some of us here as adults may have struggled with depression in the past, so we may have known someone who's had depression. And often, if you look at the characteristics, being socially withdrawn, not engaging with others, appearing to be, have a neutral facial expression or quite a flat affect, that is part of a depressive profile of need. So some young people, especially as they get older, we may start to see it, and it may present in this way. So they may see that they're not interested or they're not responding, they're not using the social skills appropriately, they're not engaging in back and forth conversation, and they just seem to have limited motivation. And often that can be confused with an autistic profile, because some of the criteria are there, with not engaging with peers, different things, but we need to be really careful in terms of the support that we offer, because obviously support for depression and low mood is very, very different for what we put in for an autistic profile. So this is just a really quick acronym for you, just to understand how we would assess the differences. So young people with depression or low mood would really struggle. We see sleep differences, so often they will have early morning waking, or they tend to struggle to fall asleep. There's a lack of interest in things that they used to enjoy, so it's about trying to explore that with them. You know, if they did used to attend clubs or they used to go to football, and then all of a sudden they're not, that's very likely going to be more around low mood or anxiety than it is around autism, because autism, we see that as like what we call a pervasive difference, so that will be different all the way from being little all the way up. Often feelings of guilt or shame about not being able to do things properly. So they may have, seem like they've got low self-esteem, or they might make, criticizing comments to themselves. The energy levels may change. So you may have a young person who is normally really engaging, happy to do the work, and then all of a sudden they seem really tired, or, just unable to concentrate. So energy levels are affected. Concentration is a massive one. So if you see a massive shift in concentration ability, and it's different from the norm, then it's obviously thinking about mood and, is there anything going on? Do we need to explore that? Appetite is also a massive one. So appetite really for autism, we do have a lot of kids with restricted eating, who limit the diet due to, not wanting to have different flavors of foods and things. Whereas an appetite in a depressive profile would be just a complete reduction in appetite, which is different from the norm. So you're always trying to find that baseline and what's different. And then agitation, so obviously emotional regulation and stress, do they appear stressed? How are they presenting? And then obviously we've got suicidal ideation as well, which tends to be, that red flag that the young person is really struggling and needs that immediate support from CAMHS or wherever, and your equivalent services. So similarities, so as I've said, I've been through that. And then how we distinguish is, as I said, the functional onset of the depression. So it's usually always quite a difference from the way that child normally is. And then if you look at section B, so the way we diagnose autism, we have a diagnostic criteria, section A and section B. Section B is very much around the restricted and repetitive behaviours. So in that section, it's the intense interest, the routines and rigidities, and the sensory behaviours. So if they're not present, and you haven't got that, that you're not seeing that, then you need to be thinking more around mood as a differential factor. So just some stats really around depression. So autistic young people do tend to have high levels of depression. And it's difficult to diagnose because the impairment in communication skills. Yeah, so I think about an autistic person who's already maybe socially withdrawn or struggling to interact with peers, and then they obviously become depressed. It's harder for us to unpick it, but we're still looking for that baseline change, and are they different than what they were? A lot of young people who are, who have good language and are able to tell us how they're feeling, they may be able to articulate that they're struggling with depression or suicidal ideation. But again, because of the differences in emotional understanding, I don't know if you've heard of alexithymia, but that is really struggling to understand emotions in themselves and others. Often they find it really hard to articulate how they're feeling. So this is why we need to be aware and have that heightened sort of sense of perception around it. Social anxiety. So this is a massive one. So to be diagnosed with social anxiety, it has to be severely impacting on your life, in addition to your baseline profile. So social anxiety is around fear of social situations, and it's obviously that fear of performance sometimes as well. So if they're asked to speak up in class, they find that really anxiety provoking. You often see visible signs of anxiety, maybe sweating, and just, they may describe hyperventilating or feeling sick in the stomach. And that tends to be related to certain situations, whether that be crowds, parties, public speaking. So there tends to be a very key factor which links to social anxiety, which then can be treated through talking therapies and things. So but autism, obviously autistic profiles of need, it's again quite hard to unpick this because often some young people aren't socially seeking. They may not want to go to parties, um but it's about really trying to dig into that with the young person and find out, did they normally used to go, how do they feel when they're there, and if they are struggling with like the fluttering stomach, feeling sick. We have a lot of young people where they end up with avoiding school completely because of this. Then it's just about really exploring it because there is a significant overlap with the two conditions. So yeah, so with an autistic profile, they generally just struggle in social situations anyway. They struggle in terms of navigating the rules of social conversations, and that tends to be pervasive. So that tends to be, all the way through primary school into secondary school. Um, and they've still got the repetitive interests alongside it. If that's so your repetitive interest in section B, your sensory differences, all of that's what you're going to be looking for. If the young person doesn't have these strong interests or the section B, um, and it's quite a rapid onset or it's something new, then we would want to be exploring a social anxiety presentation, just to really make sure that we've put that support in place and we've done the appropriate referrals. And as I say, it doesn't mean that autistic people can't have social anxiety. And I think there is a lot of diagnostic overshadowing around this, in terms of autistic people, not getting referred into services because they think, oh, it's part of autism, he doesn't want to go out with friends, he doesn't want to do this. But actually, if he is really struggling with feelings of worry around being with people and fear and he's feeling sick, there is still strategies that can be taught to support an autistic person to manage that a little bit better, sort of going through life. So we should always still be looking out for that. So, as I said, 50% of autistic children can have social anxiety. So it's definitely there. Whether all of them young people get support is different. I mean, I know where I am in Liverpool, we have YPAS who are extremely good. They have like a program that they do into primary school, and they can, they've got real evidence-based interventions that they're putting in place. But I know that isn't the case everywhere. Um, but anxiety can definitely amplify the symptoms. So if an autistic young person is not regulated because they've got social anxiety, then this is going to trigger other, changes to that young person. They may start avoiding, as I say, or you may start to have that challenge within school around behaviour and things. So it's just always good to have that consideration around, what's going on, what's changed, what's new, trying to get to the bottom of it. Um, so okay. So then OCD, so obviously you probably all know what OCD is, so obsessional compulsive disorder. Um, so again, the differences between the two are quite hard to spot. A lot of children who are autistic, they tend to have obsessional interests or rigidities and routines. So young people may say, oh, I have to go into my house and I have to switch the light on and off 10 times. So that may be a ritualistic behavior. So what I mean by that is an autistic person may do that because it makes them feel comforted and it makes them feel safe. So, I've had some very interesting ones where people are having showers a certain amount of times a day, or people are doing, different things or having to have things in a certain order. And generally people say, oh, that sounds like OCD, that must be OCD, when actually that is part of an autism diagnostic profile to have routines like that, to feel safe and secure, because to have a routine reduces the cognitive load on a young person. So they are, when they're in a routine, they don't have to think so much, they don't have to process information as fast, and they just feel safer. Whereas a young person with obsessive compulsive disorder diagnosis, they often have very, very negative thoughts attached to them routines. So it could be something like, I have to go home and turn the light off and on 10 times, or I think my mum will die, or I think I will die, or something. So when you explore it a little bit more, there tends to be some context or worry around where this is coming from. And this is how OCD is treated in CAMHS services and with CBT and different interventions. They help them to challenge them intrusive thoughts that come with obsessional compulsive disorder. But again, there is an overlapping comorbidity, so it is quite tricky. So autistic people can have OCD as well, and they still obviously need that support and intervention. So if the autistic person is distressed by the routines and they're causing them such, that they're so intrusive on their life that they can't do other things, then that's probably going to more of an OCD diagnostic profile, and they need support. So only 2% of the general population have OCD. It's not one of the more, what's the word? I was going to say, it's not one of the more prevalent mental health conditions, but 30% of autistic people. So that is a lot. If you think about the population, if you think about 1 in 100 autistic people, that's a lot of people that are going to be having these difficulties. So it's just really to be aware of that. And again, so ASD, OCD, so the stereotype behaviours that you see are going to be a lot more pronounced, and you're going to be able to visually see that anxiety when the routine or ritual is disrupted. So if you've got a young person who has routines or rigidities, and they really struggle, or they feel that they're getting like really agitated or upset when you just disrupt them with that, it could be bordering into more of an intrusive rigidity. And they do it as a way to regulate. So as teachers or professionals, we really don't want to be stopping people if they do have some kind of routines that they follow. We want to try and allow them to do that, but try and accommodate as a reasonable adjustment within our days, so that we can ensure that they are regulated. Because the issue is that we don't want our young people to start masking and trying to hold these feelings inside, because then what happens is when they get home, they get extremely fatigued. So it's just something to be aware of. So I think I've covered all of them. So yeah, OCD is the unwanted, intrusive thoughts, and sometimes the thoughts can be really, really upsetting. They can be, thoughts about really, really bizarre like really bizarre things, about things happening to people or them doing things. So it can be actually quite distressing. So I think if you are worried about that, it's good to obviously have that open conversation if you can, and try and figure out sort of what's happening. So understanding the impact. So just a little, I suppose I just put this slide in just really to consider being an autistic young person is already really difficult. And then when you've got the challenges of all this other issues on top, it can be really, really difficult to manage a school day. Um, so it's really just trying to put yourself in their position, and have that empathy and understanding of where they're coming from, and that there may be a lot going on. And this is just a quote from a young person that says, "I don't have a problem with ASD. It's just the rest of the world seems to have a problem." So a quote from a young person is that, autistic neurodivergent people feel that they're just not fitting in our neurotypical society, but it's because we're not being flexible enough, and we need to try and accommodate. So okay, so regarding attachment, so you may have done some training on this before, so it's just a little bit of a refresher. So I like to put this video on. Please tell me if you can't hear it. But I just love this video. It's so cute. So I'll just stop it. So it's so cute. Did you hear that? No one's speaking to me. Well,
Yeah,
yeah,
we could
yeah.
hear it.
Yeah. So I just play that little video because that is a lovely example of what we'd call a secure attachment style. So obviously that's Matt from Busted in the band, and he's obviously looking in his camera. He's got the little one in his eye line in the camera, and he is blowing, just blowing on, and his little one is interacting with him, and they've got that real special bond that you can actually see. Um, so attachment theory is obviously really, really intertwined with all of this in terms of neurodivergence. And the theme of it really is obviously, have we got caregivers in the young person's life that is available and responsive to the child's needs? And if that doesn't happen, or if there's a disruption in any way, then we are going to have some impact. So there's definitely going to be some impact there. So if a young person grows up and they've got someone like Matt there who's interacting with him, playing with him, laughing together, they've got that eye contact. If they've got someone who's responding to the needs, then they're going to likely grow up to have a really secure attachment style and feel like they've got a secure base at home. So that is the optimum aim, and that's what we obviously want to have for all of our young children and young people that we work with. But obviously there is some challenges to that as well, which I'm sure you're aware of. Um, so yeah, so just brought Bowlby in. So obviously he's the attachment guru who wrote all the books, and he just says affectionate bond between individuals that endures through space and time and serves to join them emotionally. So as we get older, we know that we may have a secure attachment style to our parents even now, even if we don't see them every day. We know that they're there, we know we can trust them. And if you think back to yourselves, if you've ever had a difficult day or if something happens, it's who's the first person you call, who's the first person you speak to. That likely is a person who you've got a secure attachment style and a secure bond with, and you feel like you're trusted and you're going to be heard. Um, so behavior in children with babies is innate from birth. So they have the ability to interact with mums and dads. They laugh at us, they smile at us, and they can do this from 6 weeks old. They copy us, they might pull the tongue out, they'll reach out to grab our finger. So this is all the child's actual survival strategy from birth, which is built in and a wired mechanism that they need to have this bond with their caregiver to make sure the needs are met. And they give us all these lovely interactions, just like that one we've seen, to try and make that happen. Um, and and obviously if there's disruptions to that, then we can obviously get differences. So if the little one is not responded to, then we develop these insecure attachment styles, which can then result in the presentations that we see. So you may have seen all of this before, but it's just to refresh you. So we call it internal working models. So if we've been brought up in a really, really supportive household, and it doesn't have to be perfect, they say actually the research says it only has to be perfect 30% of the time. Um, if your mum or dad was 30% of the time, responding to your needs, then you will be likely to grow up with a secure attachment style. And that means that you look at yourself and you feel like, I am lovable, I am worthy, and I can do things. I am affected. I'm effective. And then when you meet others around you, you think, oh, they're available, they're loving, they're interested in me, and they respond to me. So this is sort of this is what we're aiming for with every child. If you've had a negative experience, then you can either go, into two different domains. So we have what we call our type A attachment style, which is where we get children and young people where they're so self-sufficient. Maybe they've never had anyone respond to them at all, ever. They've been completely ignored. Or they may have been like a carer or had to do the majority of things themselves. So they become very, very independent, very so independent that they don't seek out support from anyone ever. And sometimes in life, there is some type A adults out there in the world. You may be one yourself. It is attachment style, and some adults can manage really fine being a type A. Some of them have got amazing jobs. They turn into chief execs and different things like that. But you can have, a bit of a difficult perception with other people and have that difficulty maintaining relationships going forward. So that's type A. And then we've got our type C attachment style, which is children where they've had an unpredictable experience. So sometimes the mum was there for them, sometimes she wasn't. Sometimes she was there for them, sometimes she wasn't. And that is obviously really tricky for a child. So what happens in that situation is they shout louder and louder and louder and louder to try and get that attention back. So these are our really, really these are our children where they can be quite disruptive, quite dysregulated, maybe even aggressive at times, and they will seek that attention to get that attention back. So again, both of them are very, very common. We see it quite often. And then the last one is type D, and that's disorganized attachment. And it's very, very rare that we see this, but this is when actually parents or caregivers have been frightening to a child. So the child may present as actually frightened of adults, and this is what you would call, an attachment disorder or a developmental a developmental attachment disorder. And there are children who we see with this difficulty. There are young people that we meet who've had, terrible time in the early years, and they really, really struggle with relationships, and that can lead to them feeling like they're unlovable, undervalued, everything they do is wrong, and that they're not interesting to anybody. And they think others are unavailable, so they don't trust anyone. They think others are going to neglect them or reject them, or others are going to be hostile, or they're going to hurt them. So that's the extreme, really, of a young person. And there obviously is differences in between with type A and type C. Sometimes they will have, a sense of self which is not quite accurate, and they'll need to do a lot of work on that as they grow up. But type D is obviously the most severe presentation that we see, and that can be children, in looks after situations and things like that. So what affects the attachment? So this is why we do such a detailed assessment with our young people, because we need to know everything about what's happened. And it's not that we're being nosy, or, we want to, it's that we just want to try and figure out what is actually going on. So parental mental health is a massive one. We can have mums where they've had postnatal depression. They may have got over it and things have been fine, but some of our families may have significant mental health presentations. They may have been, impatient. They may have bipolar disorder, which means that their caregiving has been very unpredictable. So sometimes they're absolutely amazing, taking the kids to Blackpool, doing everything, and then on other days so depressed that they can't even meet the needs. So you can see how that would affect. So then you've got pregnancy and birth experiences. Sometimes mums will have PTSD because of birth, which can affect that bonding. Also, parents can sometimes become really unwell, have extended periods of time in hospital away from the baby. Also, young people where they've got health conditions as well, that's a massive one, because if you've got a little one who's constantly in hospital, that's going to create anxiety in the parent, which is then going to be reinforcing that pattern of anxiety. And then also we've got miscarriage as well. So if there's been a previous miscarriage, often parents are very anxious, which can affect mental health and can affect that bond going forward. They may be too overpowering, and they create that anxiety. So yeah, so there's a lot of things that affect that. And then we've obviously got ACEs as well. So we all know about ACEs. So many different ACEs that we've got lots going on with CSE at the moment, child exploitation, even separation from parents, mum and dad, divorce, that can be traumatic. Any death in the family, any significant bullying that's gone on. And then we've got all the abuses as well, neglect and all of that. So all of these things can affect a young person's internal working model, and then that affects how they then present in school and with other people that they meet. So trauma, what is it? So I think why we're so concerned about trauma, and I think what's been proven over time is that there've been studies that the trauma response actually has physical, it causes physical changes to the brain. So it actually causes neural pathways to change and different things. So because of this, the children become very, very hyper aware of situations, and they can present with having extreme symptoms. So we can see impulsivity, hyperactivity. So all the things on there, which are exactly what you see in the diagnostic criteria for ADHD. So the way they can present is very, very similar to an ADHD presentation. So this is why we ask for so much referral information and so much history that you can give us, because we need to try and explore why. Where's this coming from? Is this been because they've been traumatized by something, or actually is this just ADHD? So 3 types of trauma. So we've got acute, which is often the simplest to identify. That could be where there's been a single incident, maybe the young person was assaulted, and then we've seen a change in behaviour. That's pretty, easy to pick up, and then we can get the right support in place. But then we have the chronic. So we have young people where they've been repeatedly exposed over the long term. And if there's obviously still things happening in that child's life, they still don't feel safe, they still are not in a secure setting, then their obviously internal working model is still being damaged. So that's why we say we need to, when we're doing diagnostic assessment, we need to ensure that we've moved the young person into a stable base before we can even start to explore, because actually, the young person is still suffering the consequences of what's going on. And then we've got what we call complex trauma, which is really severe and pervasive. So that's your children I was talking about with the type D attachment style, where they've had significant traumatic events. And unfortunately, we do see these children and young people. But I suppose just to say really is that it doesn't mean that they haven't got autism or ADHD. We're not saying that means that at all. What we're saying is that we just need to be aware, because we need to make sure that we get the right support in place. So I'm not going to play the video because I'll run out of time, but if you haven't seen it, it's a really, really good video just to show in your whole school meetings about ACEs and sort of why we need to be aware, because they're so damaging, I think, to physical health, long-term health, employment, etc. So what makes it difficult to identify? So as I said, if it's just been a one-off occasion and the parents can say, oh, this happened on the bus and they've been struggling, it's really, really easy. But if we've got young children who were exposed to domestic violence, it might have happened before they can even remember. So it's hardwired within them, but they don't know why. And obviously, we need to know about protective factors as well. And the temperament of the child is also a factor. And I mean, I've seen that myself. Some young children, siblings specifically, can be in a really, really difficult home life situation. One will end up being a type A child where they're really, really independent, they seem fine, and one will end up being a type C where they really don't seem fine, but actually they're probably affected, but just in different ways, or they've got different, different understanding of what's happened. So just some tips really of how to notice attachment style within your setting. So it's not easy, it takes clinical teams a long time to do this, but you're really, really looking at, the relationship between the parent and the young person. So is the person noticing? Are they commenting? Are they responding to emotion in the child? Are they responding appropriately? Are they validating that emotion? Are they saying, oh, I can see you're upset, what can I do? And are they are they getting down to their level and engaging? And also, is the young child, are they coming to the child, at the end of the day? Are they looking forward to seeing them? Is there obvious affection there? So these are just ideas, really. I mean, it's not an exhaustive list at all, but it's just ideas of where you can try and see, if you're worried about a young person, just to see if you feel that they are, in a secure setting. So what you can observe in body language of young children. So we've got eye contact might be reduced, and that might be different than normal. So they could feel shame or guilt about what's happening, so they don't want to engage. Body posture, they may be moving away from you. They may seem closed and really sort of hunched over and just not, just not engaged. The sense of fun might change. They might not want to engage with what you're doing. And facial expressions can often appear flat or what we call like incongruent. So, they may really struggle, they might be smiling when actually something sad has happened. So it's just not marrying up, and you can tell that there's something different. And they may react really harshly to criticism or anger. And they may get angry. So it's just some little ideas of what to look out for. So school settings are just some questions to ask yourself, really, just to keep, how does the child communicate with their parent? How does the parent respond? Who does the child go to? Do they appear relaxed and comforted in the parents with the caregivers? And does the child look after the parent? So is there an element of, the child asking whether mum's took a tablet, so whether mum's been to an appointment, and we can definitely see that in older children, especially high school, when we have a lot of our young people who may be young carers, for whatever reason. So it's just really important to be mindful of that. So ADHD and trauma. So as we've said, there is a lot of overlapping symptoms. So I really love this visual because it sort of shows you that there's about the overlap. So all of the things there, concentrating, distraction, not listening, disorganization, that is all the diagnostic criteria for ADHD. So it's really tricky for you to identify that. And I think as schools and settings, we're not asking you to do that. We just want you to maybe give us that detail of what you're seeing, but also the context of what's going home, what's going on at home as well. Um, and 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 just really to explore really. And the trauma side, you may get feelings of shame, you may get, irritability, um, but you can also get that with ADHD as well. So I think what we're saying is we're not expecting you to be experts at this at all, but just really to give us that context so we can try and understand what's happening and what's happened all the way through that child's life. Um, so as I said, why is there an overlap? And it is because of the actual changes in the brain causes hypervigilance. Um, so a lot of ADHD young people, or trauma individuals as well, they may have a real heightened sense of awareness of what's going on around them. So they may be able to, really it be in tune to like who's coming in, who's at the window, da da da, and all of that might appear like inattention, but actually it could be because they're just looking for threats, looking for danger, looking at what's around them. So that's often why we do observations and interviews, and we really try and explore that. Daydreaming and attention, especially in girls' presentation, often it can be because they're dissociating completely, or they're just shutting down because of trauma. Um, and then they may have reactions to any intrusive thoughts that are going on, which may appear to be anxiety or impulse control. But yeah, it is really difficult. And I just want to highlight again that both of these conditions can coexist. Um, and we don't want anything to be missed. So I think my key message really to you guys is if you're worried about it and you're seeing these symptoms, please still refer, because your diagnostic team will have the skills to be able to understand and to try and work this out of where it's coming from. So we don't want young people who could potentially have ADHD to be missed. So, considerations. So, just thinking about things that you can be mindful of. So, ADHD is usually persistent and pervasive, and it's seen across settings. So, generally, you would see some difficulties in school, you would see some difficulties at home. Often that's been long standing all the way through primary, going into secondary. So, you can have that history of the changes where trauma is obviously linked. Often to one traumatic event or a series of events, or if it's chronic exposure, um, then it's that history we would need to get. And I think with a trauma presentation and a true trauma, child diagnosed with developmental trauma, the presentation will change depending on situations. So if they're in a really secure, stable base with an amazing teacher who makes them feel safe and uses the trauma recovery model, often children can be amazing in them settings, but then as soon as they go into somewhere else that's different again, then that hypervigilance starts again, and you will see a change in that behaviour. So it's about looking at sort of how that works across. So case studies and assessments. This is really interesting because I work strongly with some ADHD nurse consultants. And generally we do see a lot of children who are looked after. I mean, I'm in Liverpool, Sefton, and we have quite a high population of looked after children. And they often come through for ADHD assessment. But we may figure out that they have been traumatized and they have had experience of ACEs, but then we also uncover that there's been some genetic patterns of neurodiversity. Maybe mum's had ADHD, maybe dad has. That's contributed to them struggling with their caregiving. So it's this cycle really, in this pattern. So often what tends to happen is that they may still be medicated with ADHD medication, even if we feel that the cause of it might have been it might have been trauma, because it still can support the symptoms. So some young people may be diagnosed with ADHD and trauma, and they will be treated accordingly with that. And ideally, what we would do is we would treat the symptomology in the ADHD and the inattention in the view that we really want that young person to then engage with some type of talking therapy to be able to go through that trauma and to try and process all of that. And often the ADHD being taken out and treated and supported gives the young person that time to be able to focus actually with the therapist and go through things. So it's often done in sort of that way together. So another thing to think about, so interventions for ADHD tend to be, as a school, if you put in predictable routines, organisation, so if everything has a place and the young person knows where to put the bag, where to put this, where to put that, everything's labelled, organisation. If you put organisation and planning in, and supportive strategies, often you'll see a massive improvement with ADHD. Whereas trauma, we need to do that safe base work, which is often having a supportive mentor, having a safe space. And often some young people need both, and that's absolutely fine. And I think that's okay. So yeah, but if the ADHD strategies aren't working and you feel that behavior hasn't changed, it may be because we haven't uncovered a trauma profile, and that maybe we need to go back and formulate again and figure out what's actually happening. So co-occurrence, just to reiterate again, that they are very, very overlapping. And young people with ADHD are really vulnerable to exploitation, vulnerable to abuse of all kinds, just because of the nature of the difficulties they have, putting themselves in situations where they're hanging around with gangs or, taking drugs, da, da, da. So trauma can happen because of ADHD as well. So autism, so just some stats really. So autistic people tend to be a lot more likely to have experienced trauma than the general population. So it's 10.2%. Generally, again, this is due to the vulnerability of being autistic, your lack of understanding of social rules and understanding of when people talk to you, you might overshare or give information because you're not aware of the social boundaries. So abuse and neglect and all of the unfortunate ACEs tend to be higher with autistic people. Um, and obviously the reporting rates are quite low, but it's really, really tricky in terms of being an autistic person trying to fit in a world where you don't feel like you fit. Often there's bullying, social isolation. There's so many things that can happen that just make that person feel so isolated, and then they'll have that trauma experience. So this is just a list of all of the abuse categories and all the behaviours that you might see. And then this is all the diagnostic criteria that we can sometimes see. So you can see how overlapping it is anyway. So to diagnose it and to unpick it is really quite challenging. But we are really lucky because even in Coventry, there's a researcher over there who's actually developed an assessment tool that we can use in diagnostic services to try and understand, is this a trauma presentation or is this an autism presentation? So there's a grid that you can use and it's free. So you could just need to Google Coventry Grid and you can access that. And there's also an interview now that's been produced. So what we do with our families is we'll have a facilitated discussion with them, going through the questions, and then we can sort of unpick, that's an autism presentation, that's trauma, that's autism, that's trauma. And it's really helpful in terms of understanding. So just regarding a case study, so this was a young person that I met, or a little one. She was living with Nan because she was removed from mum's care. Mum was using substances when she was pregnant, and social care became involved, and the little one was removed and started living with Nan when she was 3 due to mum's neglect. So she was referred to autism assessment, and this was because she showed some repetitive behaviour. She used some repetitive language. She'd ask questions like, "What's outside? Is that a dog? Is that a dog? Is that a dog?" And she would ask it. She would ask this continuously. She struggled with loud noises, so she'd cover her ears, and school had given her ear defenders to support. She would constantly shut the door, and she would get up and shut the door in school, which often, which was seen as like a repetitive behavior, that she'd constantly shut all the doors that she saw. She'd become really, really upset if anyone lost a temper. Um, and yeah, if she didn't get a demand met there and then, she would get really upset. She would eat her food really quickly and become distressed at meal times, and it was thought that that could be interoception difficulties around sensory, and she really struggled to be alone. So what we found out when we did the assessment, so we met actually with the social worker and with birth mum, who was quite open and honest, and she told us all what had happened. Mum was quite she was in a difficult financial situation, so if the little one didn't eat, then she wasn't given an alternative. So she remained hungry for quite a lot of the time. Parents were arguing quite a lot. There was a lot of shouting in the home, so she really struggled with hypervigilance around that. Um, and they bred dogs on the property, and there was a lot of dogs in the garden that would bark and would be quite aggressive. So the little one was obviously terrified of dogs. Um, and there was long periods of time where she was left alone. So obviously she wasn't removed from a parent from a biological parents for that reason, but the repercussions of that were still obviously present in her behaviour. So we summarised the differences using the Coventry grid. So we went through everything and mapped it all out. Um, and we did this together with Nan and the social worker to try and really help them understand, sort of what was happening. And the outcome was that we didn't diagnose the little one as autistic at that time, because she'd been removed from the place where she was struggling, and she'd been put in a place of safety where she could start to build them secure bonds. Because the thing about attachment style, and what I was talking about earlier with the A and the B and the C and the D, um, it can actually be fixed. We can always repair pathways in the brain, and we can create new neural pathways. So the little one, when she was moved into Nan's care, her language improved, engagement improved, a lot of her anxiety started to change because she felt secure and safe. And she probably needed the routines and everything to be established, but she needed them for very different reasons. It was because we needed to establish that stable base for her. Um, and her relationships improved with peers because she felt more secure, and there was less meltdowns. And we communicated that with school, and obviously sent a report with recommendations for what school could do to again create that secure base and ensure she had a person and different things. So all of that trauma recovery model stuff. So the common challenges I think for you guys as teachers and as school staff is, you are going to see it as an autistic profile, and that's absolutely fine. Honestly, I think to put a referral in and then to have a full assessment, I would always support that, because trauma can be hidden, and you may not know all the facts about what's going on at home. So, and we will always do that digging and ensure that the assessment is robust. So young people who, they may have social difficulties, they may not be getting on with peers, they may be arguing. That could be autism, but obviously it could be trauma. They could become really rigid, with rules and regulations and things like that. But again, that could be because they're just striving for things to be safe. Um, so yeah, so it's really just to reiterate, ASD and trauma frequently co-occur. So we've got lots of kids, young people who come and they get diagnosed as autistic, and they get diagnosed with a trauma presentation, but we're really clear that we put the recommendations for both in the report so that, it doesn't get overshadowed. So just quickly, because I don't want to run out of time, but PTSD is so high in the population of autism. I was really interested when I read these stats. So like nearly up to 45% of autistic people will have PTSD. Um, and often this is this is really why I think we need to promote diagnosis in this population and definitely assessment in this population, because PTSD can present so difficult that that children can really struggle, and it again leads to that lack of engagement in school and not attending and things like that, and they can experience so many more traumatic events than we do in terms of the relationships and bullying and abuse that I've mentioned already. So again, just a little visual to show you the differences between PTSD and the middle, what we'd be looking at. And again, just some data, it's just like really alarming statistics. About 60% of autistic people have had PTSD. That's a lot of people. And I think, regarding support going forward in terms of intervention, it needs to be more engaged for autistic people to support them, because often a trauma for them wouldn't be seen as a trauma for us, if that makes sense. Um, so this is just a little video again from Purple Ella. So you may have seen her. She does blogs, but she's autistic and she's got ADHD as well. And she does a really good talk about ADHD, ASD, and autistic trauma and how it presents. So I'd recommend that you watch that when you can. So autistic people, they are more vulnerable to trauma, as I've said, or the bullying, all of that. Um, and the behavior that you see may be seen as sort of behavior, may be seen as, attention seeking, refusal to comply, things like that. But often it could be what's happening in the environment. Are they actually struggling with something, what's happening right now? So that environmental consideration is really, really important for autistic young people. And I'm sure you've had a session on sensory environment, so you're going to, but that is really key to this as well. Um, so they have trauma around sensory sensitivities, communication, around changes in routine. So to us, a trauma would be, something like getting attacked or being hit by a car or something. Whereas a young person who's autistic, a trauma to them might be the hamster dying, because they're very attached to that hamster and they have a real emotional response. So we really need to be there and not minimize when people are saying that they feel upset by things. And it is definitely because of the way that they're actually wired. So there's neurological and genetic differences in terms of the brain of an autistic person, which means that they may feel things very strongly as well. So, and I've just put on there about distress and not being able to do stimming activities. So, stimming activities is how a young person regulates, how a child regulates. And what we tend to do in schools is we try and stop young people doing this because it's not socially appropriate. But actually, we need to support them to do it, and we need to try and stop them masking and just accept that that's part of them, because that is how they regulate and how they manage whatever experience they're going through at the moment. So causes of autistic trauma, as I said, it can be really, really different things that you wouldn't expect, but fire alarms is a massive one. Some young people have PTSD specifically just about the noise of a fire alarm, honestly, and it sounds bizarre, but it's true. And we've got fireworks, even paperwork. I don't know if you've ever heard of ADHD adults where they struggle to open letters or pay bills, find it overwhelming, and that's obviously like a trauma response. Pets I've mentioned, and then just comments from other people actually talking to them without being unexpected can cause traumatic presentation. So again, this is just a really lovely visual. I've got a poster of this, but it just shows you really that the sensory profile of a person, they tend to encode traumatic events really differently. So the way they feel trauma can be really, really intense and long lasting. So whereas a young person may get upset and then calm down within half an hour, an autistic person, it could take them a couple of days to actually manage that meltdown or that shutdown that's happened to them, whatever's caused that. So again, just a little visual for you regarding what we'd see as an autism trait and then what we'd see as trauma. Because autistic people who experience trauma, what you're going to see is a surge in symptomology. So you're going to see that the stimming gets worse, the withdrawal becomes more intense, any sort of behaviors or challenges that you're seeing will get worse because of something environmental or something that may have happened that could have caused the trauma. So if you've got a young person, you feel like there's been a change, even in that baseline autism that they normally show, there could be something that you need to explore and try and find out what's going on in the background. And then autistic burnout. So you may have heard of this, but it's actually quite a new thing in the research about young people who are becoming so overloaded and burnt out about trying to manage day-to-day life and putting up with all what we call these micro traumas of all these little things, that they become so overloaded that they present with burnout. And this is young people where they completely can't get out of bed, and it's linked with chronic fatigue conditions and functional neurological diseases, and also significant mental health challenges as well. So we have a lot of young people open to CAMHS, in my area where they've experienced burnout and they can't function at all. They've gone from really high achieving to now not being able to manage, and it's really, really sad. And that comes with a consequence of masking behaviours when they've not been allowed to show themselves, but also the micro traumas that they're processing on a daily basis and not having any strategies or support to manage that. So, yeah, so sorry to end on a negative, but there is things that you can do to support that. Obviously, just to have that point of safety. So even if there is one person in the school who that young person can engage with, having that mentor bond, or even having a book together, or writing notes down, or any type of communication you can have to try and identify the micro traumas is really, really good. Support with co-regulation of the nervous system. So that could be teaching them some relaxation techniques. That could be doing some breathing. It could be creating a bit of a calm down corner. I know some schools have done that in the past, where they can go to regulate and where they can safely stim if they need to. And then really just taking that time and patience to really try and uncover what's actually going on, what's happening, and being consistent about transparency. And I think explaining when things are going to change is a massive one. If you need to leave and you're not going to be there, making sure that there is someone else who's going to be that support. And practicing the power with strategies through collaboration. So what that means is, giving them that voice and giving them the strategies that they can then practice themselves. So really being empowering. So that's the end. So just to, yeah, so it's just a bit of I mean, I know we don't have very long, but it's a bit of a whistle stop tour. So does anyone have any questions before we finish? Anyone?